Hello, everybody, and welcome to the Community Care of North Carolina Enrollment Drive webinar. We're going to wait just a few minutes. A lot of people are logging in right now. We'll get started in just a few minutes. Hello everybody and welcome to the Community Care Carolina Access Enrollment Drive webinar. I am Chris Goranek at the North Carolina Hospital Association. I'm the Director of Health Policy and I work with our hospitals on how we can better support CCNC and Carolina Access across the state. Today we have Melanie Whitener, Regional Consultant for DMA, Department of Medical Assistance. She acts as a liaison between Carolina Access and community care providers and DMA, providing support and guidance to those providers and clients. Melanie?
Good morning. I would like to take this opportunity to thank you for attending this webinar to learn more about Community Care of North Carolina, Carolina Access, and enrolling your patients. We will go through a slideshow presentation which will be available on the North Carolina Hospital Association and the Division of Medical Assistance website, along with the protocols and handouts that are referenced during the presentation. If you have questions as we go along, please use the GoToWebinar control panel to type your question. We will answer these at the end of the formal presentation. We will begin with a basic definition of Medicaid. Medicaid is a health insurance program for low-income individuals and families. Individuals are determined eligible for Medicaid based on income and for adults, resources. Although a basic Medicaid eligibility chart is available on the Medicaid website, which gives basic income and resource limits, anyone is encouraged to apply at any time. Applications are available at local social service offices, online, or at many public entities like libraries or health departments. Medicaid is the largest insurer of North Carolina residents with just over 1.5 million recipients as of September 2011. The North Carolina Medicaid budget exceeds $11 billion. Despite the continued efforts of local social service staff to increase the number of Medicaid recipients enrolled in Community Care of North Carolina, Carolina Access, there continue to be approximately 170,000 eligible individuals exempted from managed care. For this reason, it was decided to launch a statewide enrollment effort to drastically reduce the number of Medicaid recipients exempted from managed care. DMA is working with many partners, including you, to enroll these 170,000 individuals with their medical home. In addition to social service staff, individual provider offices may proactively enroll their patients using enrollment forms available on the DMA website. These forms are sent to the local social service office in the recipient's county of residence to complete the enrollment process. Some hospitals have social service staff accepting and processing Medicaid applications for un- or underinsured patients. The hospital's involvement in this project does not change or add to their work responsibilities. Instead, this webinar enables hospital patient representatives, registration staff, caseworkers, discharge planners, business office managers, patient financial service personnel, and nurse managers to join in the effort to enhance a patient's Medicaid benefits by enrolling them with the correct medical home. For this project, DMA has looked at paid claims to identify a patient's Carolina Access provider and is proactively contacting these patients by mail to enroll them into managed care. These combined efforts will help us to reach our overall goal, which is to improve a patient's health and ensure their access to high-quality, medically necessary health care in the most cost-effective manner. It is important to note that although this special effort to quickly enroll a large number of patients with their medical home, enrollment is a continuous process and will not end with this enrollment drive. By attending this webinar, you will be equipped to continually use the outlined protocols to ensure appropriate enrollment for every patient that comes through your door. To make sure that everyone is on the same level of understanding about Medicaid's managed care programs, let me give you a brief description of Carolina Access and Community Care of North Carolina. Carolina Access began in 1991 as a basic managed care program to improve access to primary care and contain costs. By 1998, the program had spread statewide, and although it had greatly improved a patient's access to primary care, costs continued to rise. This led to additional enhanced models of managed care, which have evolved to become Community Care of North Carolina. Community Care of North Carolina is a nationally recognized, award-winning primary care case management model which, because of its success, has been studied by Medicaid agencies from 35 other states. Both Community Care of North Carolina and Carolina Access require additional agreements from the provider in order to participate. Both are operational statewide and combined have over 1.1 million Medicaid recipients enrolled with one of 4,500 primary care physicians in the network. Although there are a few primary care providers who have not made the transition to Community Care of North Carolina, it is the goal that every provider and every eligible Medicaid patient maximize their Medicaid benefits by being linked to a community care provider. So for our purposes, and because we do not expect you to distinguish between Carolina Access and community care providers, we will use these titles interchangeably as we move forward. Under Community Care of North Carolina and Carolina Access, patients are linked to a medical home, or what you may know as a Carolina Access provider. The medical home is listed on the annual Medicaid card with the demographic information for the office. By participating in Carolina Access, providers agree to give direct patient care at least 30 hours per week, have medical advice available to their patients 24 hours a day, 7 days per week, and coordinate a patient's health care. The medical home coordinates care so that duplication of services and unnecessary emergency department utilization are reduced, resulting in a positive impact on the quality of care for patients, improved access, and reduced cost to the program. Carolina Access does not change what Medicaid covers for any patient. However, it does change how the patient may access some specialty services. Because coordination of care for Medicaid patients is such an important component of Community Care Carolina Access, the one requirement for Carolina Access patients is that they have a referral from their medical home or Carolina Access provider prior to seeking most specialty services. There are a few exceptions to this referral requirement, including services provided in the hospital emergency department. Although hospital personnel may still follow the Community Care Carolina Access enrollment process, which we will describe later, a referral is not needed for services provided in the emergency department. Referrals are made at the discretion of the Carolina Access provider and can be made for one visit or for an entire course of treatment. It is important when making or receiving referrals that specific information is documented as to the number of visits being approved. Referrals may be made verbally or in writing and should be obtained as needed prior to rendering services. Medicaid policy states that if a provider fails to follow policy requirements to obtain necessary authorizations, then that provider may not bill the patient if approval cannot be obtained later. For this reason, it is extremely important to obtain Carolina Access authorizations prior to rendering services. Referrals are often cited by patients as a drawback of joining Community Care Carolina Access, but it doesn't have to be viewed that way. By following Carolina Access requirements and calling the medical home first, patients may find that their medical home can actually see them to treat their medical need. Patients may find that when their medical home refers them to another provider, they are seen more quickly than if they self-refer. And patients are assured that their medical home is aware of other providers they are seeing and can work with those providers to give them the best care possible. These are all actual benefits of the enrollment requirement that can be given to the patient when discussing enrollment. There is one notable exception to the referral requirement that directly affects a large percentage of the target population for this enrollment drive. Patients who are what we call dually eligible, which means they have both Medicare and Medicaid, are exempt from this requirement. This means that for services covered by both Medicare and Medicaid, they do not need a referral from their medical home in order for Medicaid to pay their bill. Having said that, the advantages of obtaining a referral are still true, and dually eligible patients can still be encouraged to contact their medical home prior to seeking care from another provider. So we have covered the key components of the basic level of managed care, Carolina Access. Now we will build on those basic components to discuss the key tenets of Community Care of North Carolina, which again enhances the Medicaid benefit to providers and patients. The key tenets of community care include that it is a public-private partnership, public entities working with private entities to achieve the same goals. Care is managed, not regulated. Protocols and processes are developed to help providers and patients both contribute to better management of their health care needs. Community care is a clinical partnership and not just a financing mechanism with community-based, physician-led medical homes. Local communities have a strong voice through community care to cause change and improve the health of their community. And Community Care of North Carolina is focused on improved quality, utilization, and cost effectiveness of those with chronic care needs. The primary goals of Community Care of North Carolina are to improve the care of the Medicaid population while containing costs, to ensure a medical home for patients, emphasizing the need for primary care, to build strong community networks capable of managing patients' care, and to work within local systems to improve management of chronic illness in both the rural and urban settings. Community Care of North Carolina meets their goals through the coordination of local community providers and primary care physicians. Each community care network hosts medical management and steering committee meetings made up of leaders from local hospitals, health departments, social service offices, and other community providers to discuss resources, needs, and new ideas that impact the care and health of local residents. The Division of Medical Assistance provides community care with access to claims data that the networks then share with their providers through the Community Care of North Carolina Informatics Center. The Informatics Center is an electronic data exchange used to identify patients in need of care coordination, to facilitate statewide initiatives, to monitor cost and utilization, and to monitor quality of care at the patient, the practice, and the network level. Different communities have different needs. When a need is identified, data is collected to support that need, solutions are discussed at medical management or steering committee meetings, and improvement initiatives are piloted to gauge success. Once a viable solution is realized, the initiative is then expanded to other areas of the state with the same need. All networks have local care managers who are typically registered nurses or social workers, and at least one pharmacist, psychiatrist, and medical director to work to improve local health care delivery. This map identifies the Community Care of North Carolina networks. There are 14 networks across the state, regionalized to work independently on the needs of their community and as a whole on the statewide initiatives. Each network provides the resources needed to care manage their enrolled Medicaid population, which has resulted in reducing costs to Medicaid. One independent evaluation states that the Community Care of North Carolina has saved nearly $1.5 billion in just 3 years from 2007 through 2009. Each network seeks to incorporate all providers, including safety net providers, and will often reach out to specialty providers when working with specific patients or initiatives. For example, allergy doctors are made aware of asthma disease management protocols. Care managers may contact a patient's endocrinologist as part of managing their diabetes. Palliative care providers have recently been brought into meetings to educate and promote their services. Networks have reached out to many hospitals to address non-emergent ER utilization, which for some communities has resulted in a care manager working directly in the emergency department. As mentioned earlier, each network has a medical management committee that provides oversight of network operations, as well as ideas and potential solutions for identified needs in the community. Community Care of North Carolina emphasizes these population-based, health management and quality improvement initiatives. Networks are responsible for the delivery of care management services to selected patients that will improve quality of care while containing costs. Although each network will develop its care management department based on their knowledge of local resources, the core processes are the same between networks. Although I will not discuss each initiative, I do want to point out 3 to give you an example of what networks do and how it reduces cost. Asthma was the first disease management initiative introduced by community care networks. It was chosen based on a review of Medicaid claims utilization data, which in 1998 showed that not only had Medicaid spent more than $23 million on asthma-related care during that fiscal year, it was the primary reason for both hospital and emergency department visits for patients under age 21. The network's aim with this initiative was to build a capacity for the routine assessment of asthma, to establish consistency of care, to build the capacity to educate patients, families, and school personnel about asthma, and to report outcomes to all providers and staff regularly. As a result, networks continue to provide data, tools, and simple-to-understand, school-approved asthma action plans to network providers, which are used within the community to better manage a patient's asthma. Palliative care was implemented based on the belief that introducing elements of palliative care upstream in the person's course of illness, concurrent with life-prolonging treatment, is associated with controlling costs. With this initiative, networks aim to improve information dissemination and access to hospice and palliative care services, increase the use of advanced care planning communication in medical homes, develop and disseminate clinical tools for pain and symptom management, psychological, spiritual, and practical needs, all appropriate for medical homes serving seriously ill patients. Community Care of North Carolina supports the integration of behavioral health services, including mental health and substance abuse, into medical homes within the network. The integration of behavioral health and primary care begins to break the silo system of care to better align the efforts of primary and behavioral health care providers. Local networks have hired psychiatrists and behavioral health coordinators to implement this initiative at the local level through education, training providers, and coordinating healthcare resources. To learn more about each of the initiatives on this slide, you may go to the link at the bottom of the slide. Well, this is the final slide describing the services offered by Community Care of North Carolina networks and providers. I have given you a lot of information about what they do, but I would also like to give you a couple real-life stories of how community care networks directly impact the lives of Medicaid patients. The first example involves a 52-year-old female with a history of uncontrolled hypertension who was recently admitted to the hospital through the emergency department for signs and symptoms of acute renal failure related to uncontrolled hypertension and diabetes, obesity, and congestive heart failure. Upon discharge, she became a candidate for dialysis. The Community Care of North Carolina care manager contacted the patient, informed her of the services provided by the network, and asked her to join the effort. She accepted the care manager's help. During initial conversations, the patient was monotone and appeared to be very upset and very depressed about her dialysis. The care manager empathized, listened to her concerns, and asked her about her knowledge of dialysis. She was very unfamiliar with dialysis and didn't really know what to expect. The care manager told her about her experiences as a dialysis nurse and reassured the patient that she could provide as much education as she wanted about her disease. The care manager attended the initial dialysis sessions with the patient and discussed concerns with staff. The care manager also gave the patient information on the recommended diet for a dialysis patient, clarified treatment times, and helped the patient understand other pertinent information, such as fistula versus catheter use during dialysis. The patient is coping much better with her renal failure diagnosis, is beginning to understand, and according to her lab results, has become more compliant with her diet. She is more confident in her care, states that she no longer feels as depressed and has set weight loss goals for herself. She calls the care manager when issues or concerns arise and has not been hospitalized since care management began. Another example involves a COPD patient with repeated emergency department visits and hospital admissions during this past summer, all believed to be due to extreme heat. She did not have an air conditioner in her home. The community care manager worked through local resources to install a window air conditioner in the patient's home. She has not had an ER visit or a hospital admission since that time. These are just a couple examples of how a care manager with the knowledge and the support of the Community Care of North Carolina program can change the direction of a patient's health, improve their outlook on life, and help them to better understand and manage their changing healthcare needs. There are hundreds of these examples, each one positively impacting the physical and emotional state of the patient served. That is what Community Care of North Carolina and Carolina Access has to offer, and it all begins with the patient establishing a medical home. Okay, now that you are familiar with Medicaid's managed care programs, Carolina Access and Community Care of North Carolina, and hopefully believe in the value of this program for your patients, we will go through the steps to ensure the enrollment of your patients into their medical home. Again, this protocol will be available on the North Carolina Hospital Association and the Division of Medical Assistance website. As you register a patient, or as you meet with a patient to discuss payment of their bill, begin by verifying the patient's eligibility for Medicaid. This should be done prior to rendering services in order for you and the patient to make informed decisions and discuss appropriate options for payment. The annual Medicaid card is no longer proof of a patient's eligibility for Medicaid. The information you should focus on with the Medicaid card is the recipient ID number shown here. Use this number to verify eligibility using an online verification tool like the NCECS web tool, which is available to Medicaid providers at no cost. Next, you must determine if the patient is enrolled with a medical home. This will determine whether or not you need a Carolina Access referral in order to receive payment, as well as whether or not you need to continue in this enrollment process. Carolina Access enrollment will be indicated on the Medicaid card just under the recipient ID number. However, just like eligibility, you cannot use the information on the card as proof that the patient is still enrolled in Carolina Access or that the patient is still enrolled with the medical home shown on the card. For this reason, verify Carolina Access enrollment when you verify eligibility. If the patient is indeed enrolled with a medical home, verify with the patient that the medical home is correct. If the patient is enrolled with the correct medical home, then you do not need to continue with the enrollment process. Obtain any necessary referrals and continue with your registration. If, however, the patient is not enrolled with a medical home or is not enrolled with the correct medical home, then continue with this enrollment process. Remember, services provided in a hospital emergency department do not require a Carolina Access referral. However, the opportunity is still there to use this process to ensure correct enrollment with a medical home. Once you have determined that a patient is eligible for Medicaid but not enrolled with a medical home, the next step is to determine the patient's Medicaid coverage category to determine if they are eligible for community care enrollment. Don't panic. This is something that you already do when you verify eligibility. Just like the coverage category code indicates if a patient has full or partial Medicaid benefits, it will tell you if the patient is mandatory or optional for enrollment in Community Care of North Carolina, Carolina Access. The coverage category is not shown on the Medicaid card. However, it is shown on the online verification tool used to determine Medicaid eligibility. These are the mandatory, optional, and ineligible Medicaid categories for enrollment. When verifying eligibility, you will see these codes used to identify the coverage category. The basic rule is this: any person receiving full Medicaid benefits is eligible to participate in managed care. There are exceptions, as noted in the ineligible column, but as a general rule, if a patient has full Medicaid benefits, they will be receiving through a coverage category in the mandatory or optional column. For our purposes, Community Care of North Carolina should be explained and offered to everyone receiving Medicaid benefits in the mandatory and optional categories. Once you have determined that a patient is eligible for community care enrollment but is not enrolled with their medical home, the process is fairly simple. If the patient is not enrolled with a medical home, explain the benefits of managed care using the tools found on the Medicaid website. Ask for information about their primary care provider or their medical home, and we will go over specific information needed in a few minutes. Complete the enrollment form. Review the member handbook, which is also available on the Medicaid website, and fax the enrollment form to the Division of Medical Assistance at the fax number given. Patients have the freedom to choose from within the Community Care Carolina Access network of providers. In addition, patients with Medicare, as well as others who are optional for enrollment, have the freedom to opt out of Community Care Carolina Access at any time. Because you will not have a list of providers within the Community Care Carolina Access network, we simply ask that you write the primary care information on the enrollment form, and any necessary follow-up will be done once the enrollment form is submitted to the Division of Medical Assistance. If the patient is not enrolled with a medical home and indicates that they do not have a primary care provider, explain managed care to them. Complete the enrollment form indicating no medical home where it asks for provider information. Explain that someone will be in touch with them soon to help them choose a medical home, and fax the enrollment form to the Division of Medical Assistance. It is not the responsibility of the hospital to help a Medicaid patient choose a medical home. However, by completing the enrollment form, not only will the hospital receive credit for enrolling the patient, DMA has assurance that the patient has been introduced to managed care and can follow up with the patient to make sure they are enrolled with an appropriate provider. A patient may tell you that the provider listed on their card is not correct. If the medical home that the patient is enrolled with is incorrect, ask the name of their primary care provider they are currently seeing, complete the enrollment form, and fax it to the Division of Medical Assistance. If the patient indicates that they want to choose another provider, but they don't know who to choose, instruct the patient to contact their Medicaid worker for assistance in finding a new provider, or indicate on the enrollment form that the patient requests assistance choosing another provider and fax it to DMA for follow-up. Make sure in this case that the patient's contact information is complete and correct. Once a provider is added or a change is made, a new Medicaid card is issued for the month in which the change is effective. Enrollment into Community Care Carolina Access is never retroactive. We can never go back in time and change a patient's medical home. Enrollment and changes are always effective the ongoing month. For example, if a patient called today, September 14th, to change their medical home, it would be changed effective October 1st. This means that the patient would need to continue seeing their current provider until October 1st, or they would need to have a referral from that provider until their card changes October 1st. This is what the enrollment form looks like. When you complete the form, complete the hospital information section, including the name of the person completing the form and a contact number. You may use a hospital stamp to identify the name and location of the hospital. Complete the patient information section. Confirming the address and phone number of the patient will allow for follow-up with the patient as needed by the Division of Medical Assistance, Social Services, the medical home, or the community care manager. Complete the enrollment form section to ensure correct enrollment. Write down as much information as possible, including the individual provider's name, the practice name, and the telephone number for the practice on the form. This will enable DMA to find the requested provider and link the patient appropriately. Ask the patient to sign and date the form and fax it to DMA. There is a second page to this enrollment form that pertains to dually eligible patients. This second page should be given to each patient who has both Medicare and Medicaid. You may encounter a patient who is mandatory for enrollment but is unwilling to give you information about their primary care provider or who is adamant about not joining the program. In this situation, document the patient's response on the enrollment form and say to the patient, "Someone will follow up with you about choosing a medical home and will be able to discuss your options," and just leave it at that. DMA will then perform the necessary follow-up. Here are some reference sites for you. The North Carolina Hospital Association website, the Division of Medical Assistance Community Care Carolina Access webpage, the link to Community Care of North Carolina, Carolina Access Member Handbooks, and the link to find out more about Community Care of North Carolina. This concludes the formal presentation for the enrollment drive. We will now open the floor for questions.
Hi, this is Chris from the North Carolina Hospital Association. One question that was asked is the fax number that we provided to DMA specific to the Carolina Access?
Yes, the fax number on the form is directly to the Division of Medical Assistance, the Managed Care section, directly to Community Care, Carolina Access Department. Okay, the question was asked, can a provider enroll a patient in Community Care of North Carolina? Yes, providers have actually been able to enroll patients in community care for some time. There are enrollment forms on the link, see if I can go back, the DMA Community Care of North Carolina, Carolina Access webpage. If you scroll to the bottom of that webpage, there is a link to enrollment forms. Providers can use these enrollment forms and send them to the local social service office in the county where the patient resides, and social services will actually complete that enrollment process and link the patient.
Another question was asked, are we no longer supposed to fax the form to the appropriate DSS office?
For purposes of this webinar and to educate affiliates of the North Carolina Hospital Association, we've made available for specific forms to come to DMA Managed Care. If an individual provider office is completing enrollment forms to enroll patients with their office, then it is still appropriate to send those forms to the local social service office. Hospitals may use the 919 715-0844 fax number.
Will we be able to access all of this information online afterwards? We'll have a lot of this information available on the NCHA website. Community Care of North Carolina will dedicate a portion of their website to this information, and all of this information is obviously available at the DHHS website. One question was asked about nurse practitioners and how nurse practitioners are used in the community care networks. The way, as I understand it, that community care works is it's a grassroots effort bringing in all community stakeholders, and so nurse practitioners are used in very differing roles depending on the community needs. Some points they may be able to have a nurse practitioner act as a care manager. At other points they're clinical support, quality improvement, or they work just as clinical advisors. Another question came up, will Health Choice be part of this enrollment drive?
At this point, North Carolina Health Choice is not part of this effort by the hospitals. However, we will be enrolling in North Carolina Health Choice recipients into Community Care of North Carolina in the coming months.
One question was asked, is my clinic supposed to enroll MQB patients as well? Would they be enrolled through this enrollment drive?
If your MQB patient has Medicaid benefits, then there is a possibility they could be enrolled. MQB typically is for patients who do not technically qualify for full Medicaid benefits. Medicaid pays for their Medicare premiums, but they typically do not actually receive a Medicaid card. There is one category of MQB that will receive a card and that is eligible for some coverage through Medicaid.
Another question was asked if we could go back and review who has Medicaid and Medicare, what the differences are, and how that affects who can be enrolled.
Can you repeat the question? I'm sorry.
The question is, how does Medicaid and Medicare, how do those differences affect whether or not you can be enrolled in Carolina Access or CCNC?
The Centers for Medicare and Medicaid have mandated that those who are eligible for both Medicare and Medicaid remain optional for Carolina Access enrollment. We are encouraging and proactively reaching out to this population because, as we all know, given the benefits we have just described for community care, these patients would greatly benefit from someone being able to help them navigate the Medicaid system and help them adapt to their changing healthcare needs. But the mandate comes down from the Centers for Medicare and Medicaid that this particular group remain optional for Carolina Access enrollment.
What if a patient only has Medicare but does not have Medicaid?
Then they're not part of this program at all. If they do not have Medicaid, then certainly they would not be eligible for any type of managed care enrollment with Medicaid.
Another question was asked, how do you handle the situation where the client refuses to engage with the community care or Carolina Access primary care provider?
primary care. Go ahead,
Sorry,
I'm sorry.
the question really is, what would you do with a client if their provider that they're currently seeing refuses to engage with community care or Carolina Access, if their primary care physician is not in managed care?
So to make sure I understand, the patient has a medical home, but that medical home is not part of the network, correct? In that situation, and because the hospitals will not have a list of participating providers, that's why we simply ask you to complete the enrollment form and send it to DMA. At that point, if we identify a provider that is not part of the community care network, we would reach out to that provider to assess whether or not they are interested in becoming a provider. If they are not interested and the patient is mandatory for enrollment, at that point we would explain that they would need to change providers. If they are optional for enrollment, then they would have the option of either changing providers or opting out of community care.
Question was asked, what is our description of the best practice model for hospital staff to identify and register clients into Medicaid managed care? First, we need to identify where within Medicaid they fall, what coverage category they have. Once you do that, you can clearly gauge whether or not they're eligible or ineligible. If they're ineligible, the Carolina Access Managed Care Services are not available to them. If they're optional and or mandatory, then they are available. Again, the general rule is full Medicaid insurance typically means you have access to Carolina Access or CCNC. A question was asked, are behavioral health patients handled differently with respect to their medical home and services provided in a hospital ED? No, again, we must return to what their original Medicaid category is and whether or not they have access to a CCNC medical home. If they do, then we recommend that you fill out the form and explain the benefits of managed care. Now, if they're in your emergency department for behavioral health issues, it's also appropriate to contact the local LME. Carolina Access and CCNC can help you with that, and that's a great benefit and a great help when a care manager, once contacted that one of their patients is in your ED, can reach out to the LME and help coordinate services. One question was asked, what is the difference between straight Medicaid and Carolina Access?
The difference between straight Medicaid and Carolina Access Medicaid is the referral requirements. Coverage is the same whether or not a person has a medical home listed on their Medicaid card, but the process for accessing services changes once they become part of Carolina Access and Community Care of North Carolina.
clarification question came in. If a patient has Medicare and Carolina Access Medicaid, a Carolina Access provider referral authorization is not required. Correct?
It is not required for claims processing. The claims, typically when a patient is dually eligible for Medicare and Medicaid, claims are submitted to Medicare and they automatically cross over to Medicaid. Medicaid in that situation does not look for Carolina Access authorizations. So that is correct that the referral is not needed for claims processing. However, we discussed the benefits of obtaining a referral and contacting the medical home prior to seeking specialty care. Those benefits still remain the same.
If the patient is in the emergency department for involuntary can we still approach them and have them sign the form for enrollment? Yes, of course you can. After they have received all appropriate treatment and care, it is still appropriate to engage them in a conversation about the benefits of managed care. And if they've already got a medical home, it's also appropriate to communicate with their care manager. Melanie, a question came in about the timeline for the enrollment drive. And will the Department of Medical Assistance be sending out letters to our Medicaid recipients? What else is happening on the DMA side for enrollment?
Medicaid is, we have used claims data to generate reports. Some patients we have identified Carolina Access Community Care of North Carolina providers that they are seeing. In some cases, the patient has not been touched by a community care or Carolina Access provider. We are sending appropriate letters to all the individuals on these reports. Our goal is to enroll as many of that 170,000 recipients as possible over the next, let's say for the remainder of this calendar year. So DMA is working, as well as social service offices are putting forth special efforts. We are communicating to provider offices to put forth special efforts. We are very grateful that the Hospital Association and the hospitals are willing to put forth special efforts to get as many patients as possible enrolled in community care.
Question. For hospitals already enrolling Medicaid managed care clients, where does this typically occur? I.e. in the emergency department? We think that everybody in the hospital that has discussions with the patient about insurance coverage, Medicaid categorization, and the appropriateness of a medical home can take part in this enrollment drive. It's going to be very beneficial and helpful to DMA to have the information on the form coming in from anybody that touches that patient and has the time to discuss managed care. Many people that can do this include patient representatives, caseworkers, placement staff, and others. Can we find out which hospitals are participating in the drive? NCHA is asking that every hospital participate in this. This is very integral to managing our Medicaid population, giving them improved health and better resources to support their healthcare needs. This also speaks directly to hospitals' efforts to help CCNC reduce overall costs in the system. So what we would like is that every hospital encourage their patient representatives and staff to engage in this process. DMA has hired multiple additional workers to help in the enrollment process. The forms going directly to DMA will be counted and tallied to let us know at NCHA and CCNC where those forms are coming from. So we'll be able to discuss that with the hospital leadership and let them know how many forms and how many patients they discuss managed care CCNC with. We will make available the enrollment letters coming from EMA available on the DMA website through Amelia Bryant at NCHA, as well as the NCHA website. Well, we're nearing the hour mark, and I think that we have answered as many questions as we have time for. So thank you all very much for participating. We're going to end a little bit early to give you guys back your half an hour of time. We thank you very much for participating. And feel free to contact me, Chris Koronic, at NCHA, or Melanie Whitener at DMA, or Amelia Bryant, also at NCHA. Again, we're going to make all these materials available at ncha.org, on DMA's website, as well as on CCNC's website. Thank you very much.
Thank you.